Yeah, let's go along.
Good morning, everyone. Welcome to today's clinical case presentation.
Can you increase your volume, please, a little?
Yes, sir.
Yeah.
Now, sir?
Yeah, that's
Little
better.
more?
Yeah, better.
Sir, our patient, 30-year-old female, presented to us with a history of pervaginal urinary leaks since 2 months.
Okay. So I want to know the antecedent history, sir. Actually, any history of surgery or childbirth.
Yes, sir. I'll be covering in next slide, sir.
Okay.
The history starts with spontaneous abortion around 2 months back. Following that, the patient had a severe vaginal bleed and hypotension, for which she was admitted in ICU. And on the same day, she underwent emergency abdominal hysterectomy.
Okay.
And on the next day after surgery, she noticed a continuous leak per vagina, and she was not voiding in between the leaks. And there was no, however, there was a Foley catheter which was there in place, but there was no increase or decrease in quantity of leak on change in position, whether in supine or standing position. And she used to use diapers, around 8 to 10 diapers per day.
Okay.
Do you want to ask any specific question on this so far, Kamraj?
Yeah. They have given history of abdominal hysterectomy, sir.
Correct.
Whether that point of, at the time of surgery, have they identified any injury? I want to know.
Okay. As per the operative notes available, they not mention anything of such sort, sir.
Okay. So since urinary leak from the next day after surgery, so I want to know what they have done actually. The hospital.
What was the diagnosis? For hysterectomy, what was the diagnosis?
So spontaneous.
Sorry?
Yeah, so they are spontaneous abortion and vaginal bleeds, sir. So hypotension. So it's maybe some postpartum, not they want to control the bleeding, and so they have done a hysterectomy.
Is it possible that the spontaneous abortion contributed to the bleed and to the ureteric injury or whatever injury? Sorry.
Abortion cannot contribute to the injuries.
Yeah, please, all of you remember, any pregnancy results in pelvic congestion. The veins of the pelvis become prominent. The cardiac output is shunted through the pelvic veins more than earlier. And there can be a problem if the bleeding starts suddenly. Okay, pregnancy is always associated with vascular congestion in the pelvis. Even if it's an abortion.
Abortion. You want to know anything more about the abortion?
Yeah. Was the hysterectomy done after the abortion or before?
No,
After the abortion on the same day.
Same day.
Abortion.
Emergency hysterectomy.
So where was the abortion done? Did that contribute, did something during the abortion contribute to the hysterectomy?
Yes, sir. Bleeding, subsequent to abortion, bleeding, and she was in hypotension.
See, you know what you have to ask for here specifically is,
Sir.
Was the abortion done in a hospital by an obstetrician, or was it done by somebody else in some small clinic?
Or did she abort spontaneously at home and come running to the hospital?
Yeah.
You see, or did she do something? Because this is well known.
Yes, sir.
Smallest amount of, postpartum bleed can become a torrent. So you don't have to, it is related. There's no question about it. The two are related. The issue is that she has abortions before.
Previous history.
No, this is the first child. She's 30 years old. This is a precious baby. All this,
This was a third pregnancy, sir. And previous two childbirths were normal. No previous history of abortion, sir.
Okay. What else would you like to ask on this? Urinary leak from the next day after surgery. It's very evident that.
She is continuous, so she's not voiding in between.
Yes, but she's got a catheter, no? They said she's got a catheter.
Yes.
Anything particular you want to ask about this? And she uses 8 to 10 diapers per day, pads per day. And she's also on a Foley catheter. You see, Dr. Mohan, I think inadvertently mentioned ureteric injury. When an emergency hysterectomy is being carried out, nobody is bothered about anything except the life of the individual. The baby is gone. And you don't bother about the anatomy there. You want to control the bleeding, so whatever happens, you want to take everything out. So there will be a team of surgeons whose hands are all over the place and trying to control the smoke, this, that, everything. So take it. So you don't know what you have injured in the process. You could have injured both ureters, you could have injured both ureters and the bladder, you could have injured only the bladder, so any possibility. You could have injured the urethra. The entire urogenital tract can be, so the history must be such that you ask, she's on a catheter. Is there any urine coming from the catheter at all? Is everything coming through the pad? Number one. Number two, is there an equal amount of urine coming from both? The urine output from the catheter is significant. It tells you and quantifies as to what could be the size of this hole. Supposing a ureter is injured, she may be leaking urine through the ureter and a good amount of urine in the catheter. Just, we have to try to get that from the history. It may be wrong totally, but you have to find out whether these things actually are there. Right. So, what are you going to do now?
Yeah, the history is more probably suggestible.
No. Whatever it is, she's leaking urine through the vagina. Do you want to know anything more about her?
So for the past 2 months history.
Yes, 2 months history. Correct.
So I want to know about the local site of excoriation, all those things.
Find out all that. Ask all the history, relevant history.
She's on diapers, so I want to know.
Okay. Ask him the question.
Yes. No issue of pain, fever, hematuria, perineal itching or irritation.
Number, why this perineal itching and irritation?
It's a chronic exposure, 2 months continuous exposure to the urine.
See, this is where you should not get distracted. Mass per vagina, perineal itching are irrelevant.
Comment on this mass per vagina.
Hey, any history of associated prolapse of the cuff, sir?
Forget all that.
And hysterectomy.
30 years and she's gone emergency hysterectomy.
It's only 2 months.
Prolapse in 2 months.
Okay.
Only 2 months.
Okay, sir.
Why pneumaturia?
In the wham bam activity, whether any bowel has been injured.
Possible, isn't it?
Possible. Anything is possible, man. In an emergency situation, sigmoid is sitting there. You have already caused so much of harakiri here to the urological tract. Same thing can happen there. You don't know. Any other relevant question regarding her pregnancy you want to ask?
More obstetric history.
Yes, obstetric history. He only said 2 deliveries. Anything more you want to ask?
Previous any.
Were these vaginal deliveries or were they cesarean sections?
Normal also any.
Ask him, I don't know. He didn't tell us. They were vaginal deliveries or was it a Caesar? Because Caesar means some more additions. Just makes the operation a little bit more difficult. You want to get to the,
Want to know the obstetric
the
history.
difficulty index, yes, of this whole procedure.
I think we should also remember that if someone has had a vaginal delivery and it's the 3rd pregnancy, very unlikely that there will be a spontaneous obstruction unless there are endometrial adhesions or it was a tubal pregnancy.
Right.
Treatment history, sir. But, as I already mentioned, spontaneous abortion 2 months back, following which she had 7 units of blood transfusion and underwent the same day emergency abdominal hysterectomy. And urinary catheter was there for 1 week and subsequently it was removed.
Okay.
that key question has still not been answered. Was the catheter draining any urine at all? You saw how much. Remember this in your exams? It's
Yes, sir.
important to know.
Yes, sir. On examination, her BMI was 30.8 kg per meter square with performance score ECOG 0, pulse 88 per minute, and it was regular. BP of 126/84 millimeter of mercury. On abdominal examination, scar of previous surgery, that is of abdominal hysterectomy, scar was present. Otherwise, abdomen was soft and non-tender. There was no palpable mass or organomegaly.
Anything significant here?
BMI is 30.8, sir. So,
Yeah. So obese patient is more prone to fistulas. Okay.
On vaginal examination, there was a continuous urine leak from the vagina, and on perspectival examination, there was approximately 1 centimeter defect in the anterior vaginal wall at a level of vaginal cuff with continuous urine leak. There was no induration or tenderness, and the edges had healed, sir, in the examination. That was after 2 months.
See here, you don't say vaginal cuff. You say deep in the vault.
In the vault.
Vaults, okay. And rest of our systemic examination was within normal limits, sir.
Although it is not relevant in this case, sometimes in an emergency situation, people do a subtotal hysterectomy. And a little bit of the cervix may be left behind. And that you may be able to see or palpate. So it's a relevant negative. It's because it's an emergency situation, your life and death. So the easiest thing to do is to take the uterus off and close the cervix and leave it. That's one way. So check with that. That's important to know. Anyway, he said the vault. So vault is just the edge, but whether there was any cervix seen at all. Huh?
Most likely diagnosis is Vesico Vaginal Fistulae, sir. I want to rule out even concomitant any ureteric injury. Also.
Yeah, so what to do?
So I will do a CCT extra.
You will do CCT. Before that? You want to do anything else? She had 7 units of blood, man.
Now they were told hemoglobin to create your
It's all right, eh? They didn't see the value. They put a value, hemoglobin? Did you put a hemoglobin value?
No, not yet.
Not yet, yes.
Yeah, show us the investigations, please, Imran.
Yes, sir. Hemoglobin of 10.8.
It's not the world's best, but still, for somebody with a BMI of 30, she would have been from a reasonably good background to have that BMI. Hemoglobin should have been good, but it hasn't picked up yet. 10.8.
And 2 months is a pretty long time.
And albumin is 3.7 grams, So, these are important considerations in a patient where they present a case like this, because ultimately you will have to operate. This is not going to get patchwork with gum. So when an investigation like this is being placed in front of you, in your mind you must start beginning to think and actually tell the examiner these investigations. He may ask, that's what it is. This hemoglobin is only 10.8, sir. It is, we expect it to be slightly better. Albumin is still slightly on the lower side. So she's still not completely, she's still under the weather, as they call it. She's not completely recovered for somebody of that stage. Okay? So, these are important considerations when you are going to operate on somebody. All right?
Morning, sir.
Morning. So, what are you going to do now?
For CCTs.
Huh?
I'll go for CCTs.
You will go for CC. You're allergic to contrast. Allergic to contrast.
And we can do the.
What do you do? She's allergic to contrast. You can't do it. She'll have another catastrophe. Huh? So how will you? What do you do now?
We can do the 3-gauge test, 3-pack test actually.
3-pack test. What are you going to do with the 3-pack test?
You can know whether there's any ureteric leak is also there.
All right. So you do the 3 gauge test. 1 centimeter hole is there. Is there a problem with that? 1 centimeter hole?
That's the obvious defect side.
That's an obvious defect. But how is it going to vitiate your 3-pack test?
We want to know any concomitant ureteric.
That I understand. You want to know any concomitant ureteric injury. But will this 1 centimeter hole cause a problem in your interpretation of your 3 swab test?
Sometimes the whole thing may be draining uterus.
Yes, it is a problem, isn't it? The hole is so big, you don't know whether it's leaking from here or from there. Both it could be happening. So what will you do? The 3 swab test is fine. I'm not saying it's not it, but when you do a test, you must know what could be the likely interpretations. Because with the catheter, we don't know how much is draining. Obviously, everything is draining from here. So what will you do now? Allergic to contrast. 3 swab test was neither here nor there. So what you will do?
Proceed with cystoscopy under general anesthesia.
You will proceed with cystoscopy under general. You will do anything else under general anesthesia?
You can go for retrograde pyelogram or ureteroscopies, depending upon those.
Which one will you do? Retrograde pyelogram or will you do ureteroscopy? Hello? Are we online or they are on? Off?
Hey, these slides have gone off. You have to share your presentation again.
Sir, we lost the computer. We'll reshare.
Okay. I don't know whose connection went off.
Sir, our connection had some issues, sir. We'll just sharing.
Okay. Were you able to understand why the 3 swab test could cause a problem when there's a large hole?
Yes, sir. The entire swab will get
Also, when an emergency hysterectomy is done, you don't know how much of the vagina has been removed. Okay, so she could have a narrow vagina. It's important when you examine whether it's a narrow vagina, because if it's a narrow vagina and a ureterovaginal fistula is also there concomitant. We all close. Ureterovaginal, BVF, the whole works. You don't know where it's coming from. Urine is all over the place. So the level of the introitus from the skin to, from the introitus to the edge of the vault, you must know how shallow. It is a big lady. I mean, 30 BMI. So, you need to find out. It's important in the physical examination. So what will you do under anesthesia? That's what I'm asking. She's allergic to contrast.
So you have to see any other fistulas opening in the
So what will you do? I'm asking you, what will you do? You only said cystoscopy.
Either retrograde pyelogram or ureteroscopies.
No, which one will you? Either this or that means what? You are leaving the choice to me. You are the fellow man who was going to do it. So you have to tell what you will do. Don't leave the choice to the examiner.
I prefer RGPs.
You will prefer RGP. Anything else you will do while you are there under anesthesia? Hey Baba, want to examine vaginal
It is
examination?
part of any
examination? Yes, I am.
To
We have not done anything under anesthesia, man. He's only told you that there is a hole there, that's all that you can see. You have to examine under anesthesia. You have to see how the vagina is it all healed up? Is it all still supple? Ultimately, you are going to do an operation there, no? So under anesthesia, you have to make an assessment of all this. What is
You
the
do a
depth of-
bimanual examination.
Bimanual, what is it all fixed on one side? Tissues, it's only 2 months, It's very important. What is the length of the vagina? It's very short, introitus. All this will tell you what sort of approach you will use, how difficult it is going to be, and from part of counseling of the patient. Understand? Because the worst thing that can happen is to have an incontinent woman. Very bad. It's the worst of all the problems. Worst of all the non-cancerous conditions, if you ask me. Incontinent man, you can put a clamp on the penis. Where you will put a clamp on the female? Very difficult. It's the most disastrous, non-cancerous condition for a woman. Huh? So what do you do with the cystoscopy?
You have to visualize the whole bladder, sir.
Okay.
Apart from the main this defect, any other defect is there?
Yes. What apart from the defect, what else in the defect you will do?
You are doing cystoscopy, the water is continuously leaking per vagina, and you're not able to distend the bladder.
Can you do some maneuver which will help you to fill the bladder to some extent?
So per vagina we can close the
So what you tell only what you'll do for vagina, what you'll do?
per vagina we have to apply the tamponade and the
Okay, you will put a finger at the edge of the fistula because only 1 centimeter. You may be able to occlude it and thereby fill the bladder. Huh? Okay? Huh? And see what happens. What are the other things you will see when you do a cystoscopy in such a patient?
so we have to see the urethra also.
You will see the urethra, very important, very important. You forgot that. What else will you see?
So urethra bladder and both the ureteric orifices you have to see.
Then what else will you see in the bladder? I am not finished. I am not going to let you go. You have not told me what you are going to see in the bladder. I know you will see the fistula. Will you see one fistula or 2 fistulae?
You have to search for it.
You don't know. There may be more than one hole there. This is an emergency hysterectomy. We don't know what the hell has happened there. They have seen only one hole. There may be another one tucked in somewhere. Huh? Anything else you will see? You said ureteric orifice. What about the ureteric orifice? What about the ureteric orifice is that you're going to note in particular?
Efflux you have to see.
Efflux, okay, you will see. Right. Anything else you'll see about ureteric orifice?
The shape of the orifice also you have to see.
Shape of the orifice. Okay.
Even more important.
And more important than the shape and anything else. It's got relevance to the operation that you're planning, man. Huh? Sorry? This where the ureteric orifice is, vis-a-vis the fistula. Is it bang on? Is it away? Is there one orifice or 2 orifices? We don't know. We have not done any contrast study on her. She's allergic to contrast. There may be 2 ureters. You don't know anything. You see, this is the problem with this situation in VVF. The assumption that the woman has got only one fistula and the assumption that it can be repaired very easily. Right? So, remember, the first time in is the best time in to repair a fistula. As you increase the numbers, the success rate keeps going down and down. So it's very important to make sure that you get all your information in that cysto under anesthesia. That's why you do it under anesthesia. No? You want time, you want comfort. And never do this under local anesthesia. Never. Uncomfortable for the patient, uncomfortable for the surgeon. You tell them straight, I will not be comfortable doing your cystoscopy under local.
Grossly inadequate.
Yeah, and that too one fat lady like this. Very difficult. You will be groping there in the vagina, fiddling around, uncomfortable because she's under local. She'll be squirming, you will be squirming. Oh, it's a bloody craze. No, don't try it at all. Don't try it. That's why you say examination under anesthesia. Comfortable.
Nor should you do it just before the repair. Do this at leisure and then plan the repair.
Correct.
Many have this habit, table lepathic lampa. No, this has to be done.
You won't know what to do. Because you have to tell the patient, no, what I'm planning to do, what is the difficulty. So, very important. Since you do not have a contrast study, you will have to imagine what I'm going to see in the contrast study and try to replicate that at the cystoscopy and proceed. She could have 2 orifices, 3 orifices, God knows how many orifices.
Sir, can we do a MR urogram instead, sir?
Hey guys, I'm asking you again and again. Don't interrupt the person who is discussing. Your questions will come at the end.
Okay, sir.
Now, anyway, now that you asked the question, can you do MR urogram? Can you do MR urogram, comrade? We want to know whether the MR urogram is a substitute for a cysto under anesthesia. Is that what you want to know? You can do anything you want. After MR urogram, will you still do cystoscopy, man?
Yes, sir.
Then what? What's the great fun? See, the important thing is the history. Here was a woman who has had 2 pregnancies, nothing wrong with her ever. She has been in good health apparently, normal creatinine. All right? And therefore, you do not anticipate anything grossly wrong with her kidneys. So if you are, pushed to the wall, if you're really pushed to the wall, you're the back of beyond in a place where you don't have any facilities. This is what you can do. You can indirectly assess the upper tracts by doing an RGP, seeing what the collecting system looks like, see where the orifices are, and you will get an idea. I mean,
You also know the contour of the ureter,
everything.
whether it has been pulled medially, laterally, whether it's distending or not distending.
Everybody would certainly do some form of imaging in this lady for very important reasons. All right? Because you want to be as non-invasive as possible and get all the information in a non-invasive fashion, then you proceed. But in places where you work, sometimes you go to some small peripheral mission hospitals, this, that, everything, they may not have enough of what you want. You will have to jugaad, you will have to think out of the box and say, okay, this is what I want to do. You're leaking woman. So that's what you will do. Right, so you can do an MR urogram. That's the answer.
Okay, sir.
So what was done then? What investigation?
Creatinine, everything's normal.
Yes, so did you do a CT or MR?
Did a CCT, sir.
Okay, show us the images.
Sir, I have full CT also. If you want to see, I can share. I have put only few images, sir, but I have full CT also to run through.
Remember what?
Show us a representative
remember
image
what
of the
Dr. Mohan said.
abstract.
We didn't get what you said, sir.
Sorry? No, when you put images of this nature, remember what Mohan has been talking about when you put images rather than the whole thing? They should be a sequence. We are looking at kidneys. Come down from the kidneys, slowly show us the ureter, then show us the bladder and everything else.
I will show the full CT, sir. I will re-share it.
Okay, before you show Imran, let's ask somebody who's done this CT, what do they expect to see so that you can choose those films alone for the presentation? What are your interests? Those points of interest can be put up instead of the entire 40 or 44 plates that they give us. You're interested in the kidney. You're interested in hydronephrosis. You're interested in hydroureter, the route of the ureter, the distensibility of the ureter, as far as the upper tract is concerned.
Yes.
In the lower tract, it's unlikely you can make out much other than urine pooling in the vagina. Okay, so once we are clear about this, for your presentations, you can choose the appropriate exposures.
Right, sir. Shall I show the full CT, sir?
Yeah, just show. You have no choice now. Are these the kidneys?
It starts in this order from our seat.
Okay.
I'll call you back after class.
Wait. Do you see anything in the kidneys? Any hydronephrosis,
No,
distended pelvis, anything?
no, sir.
Look at the left kidney and the pelvis.
At this point, you will say that this pelvis certainly looks a little bit more prominent, but I would like to see the rest of the films to know. Why do you want to say that?
Putting up lower tracts
No. Why do you want to say that? Why do you want to make that statement and get out of it?
can be extrarenal.
Correct. It can be an extrarenal pelvis.
We can't hear you, Kamraj.
Can be extrarenal pelvis, sir. So we want to know the full concept.
Okay. Right.
Hang on there. Just hang on there. Anything you can comment on, Kamraj?
So the bladder is getting full up, but you can see
Sorry?
You can see that?
Didn't hear you.
If you're not sure, ask him to run the series back again. If you missed something, ask him to run it back.
just
Don't feel shy, man.
Go up a few frames, please. Go caudal a few frames. Now go up, yeah. Go cranial. Cranial.
Yeah, what is it? Okay, now go down now. Go down towards the bladder. Watch carefully now, Kamraj. All right. So what do you see there?
Left side there is no appendixal lesion also there, sir.
Left side?
Appendixal lesion also there actually.
No, you start. Both kidneys, are they there in the normal place?
Both kidneys are in.
Are they functioning well?
Yep.
Is there one ureter, two ureters?
Shape, contour, all the same.
Everything. Yeah. Then what do you do?
No hydrohydrotonephosis.
All right. Then
It's all both single ureters on both sides.
what else do you see?
So you can see the dry extras.
No. Do you see the ureters in their entirety, all the way down to the bladder,
Yes.
both sides,
Yes.
right and left? You're sure?
Left side actually we saw its lesions.
What do you see on the left side? Go up a little bit, bend towards the kidney. Slowly go up towards the kidney.
Yeah, stay there, stay there. No. Come down a little. Yeah, stay there, stay there.
Air pocket actually.
Huh?
Air pocket is
Okay, air pocket is open to the atmosphere. That's a different matter. Something else. What else you observe? Are both ureters seen?
They're seen up to the lower levels after that.
No, you see. Go up a little bit, man, towards the kidney. Go up towards the kidney now. Imran, go up towards the kidney.
Cranial, Imran, cranial. You're
Okay.
going down, go up, please.
Stop there. Stop there now. Stop there. Now what do you see?
Right frequencies.
Huh? Do you see the right ureter? You don't see.
Yes.
Where is the right ureter? And what is this swelling that you see here? Do you see that swelling? That's the bladder? Is that the urinary bladder that's swelling? Because the ureter is now very close to that.
It's not in the middle.
Huh? No, what is it?
Any adnexal lesion.
Adnexal lesion. Anything else? Something more relevant to the problem at hand.
Collection.
Huh?
Collection, but it's more. It's very.
What? It's 2 months, man. 2 months, it's got a wall, it's got fluid, it's thick there. So what? It could be a collection of blood, it could be old blood, it could be urine, it could be pus, anything it could be. No?
Looks more circumscribed.
Whatever it is. The commonest thing is urine is flooding all the place. The urinoma will form, it insists itself, collects itself. Huh? But is there any contrast entering it?
Most.
It is important to know that. Supposing contrast is entering into that, then what will you take?
This collection urinomas.
What else will it infer?
That's ureteric injury.
The ureter is involved in that. The ureter is involved and is leaking into that. So that's why you see the course of the ureter as it comes down, it's a little bit dilated above and then it becomes normal again. As it is coursing over the pelvic brim. You are not seeing the right ureter at this point. But you don't know whether it is seen below or not seen below. You go down now. Carefully see. Are you seeing the right ureter still? No. Are you seeing the right ureter still?
No.
You see the left ureter? Nicely going, huh? Where's the right ureter? Go, see. You are seeing the right ureter definitely, because on the images of the kidney, you can see the ureter come right up to the pelvic brim.
The trouble is at the brim. Beyond that, you can't see. And you'll also see there's a lot of soft tissue thickening in that area.
So it must be noted that while the left ureter is seen nicely draining, you see it goes going out all the way there, right into the bladder. Nicely. And then you see the fistula. Alright? But where you correspondingly should see the right ureter, you're not seeing the right ureter, you're seeing the bladder. Maybe it is overshadowed by that, we don't know, but we're not seeing it elsewhere too. You know.
Okay, let's move on.
Carry on.
Yes, sir.
The report, sir.
Okay. So what do you do now?
So she's 2 months. This is 2 months history and depending upon clinical conditions.
Ilapa, do you want any more imaging or endoscopy, or are you willing to now start management?
Yeah, the diagnosis confirms it's a vesico vaginal fistula.
What is confirmed? Nothing is confirmed. You can't see the right ureter. What happened to it? We must know this before we enter the
The radiologist has reported that both bilateral VUJ appear intact. They have reported. Do you believe the radiologist every time? He is not going to put knife to skin. You are going to put knife to skin, no? So, even though this report is there, you need to confirm it. If you are not happy and you are not convinced that, okay, it's not very clear, you make it, convince yourself. So, will you still do a cysto-EUA on this patient?
RGP search.
No, you will do a cysto-EUA. You will do it. Make sure what's happening here. No?
Still, you have done.
All right. It's not infra-dig to do a retrograde bus. For some reason, the retrograde seems to have fallen into disrepute in urology for, I don't know, in the present era. Yeah? It has its role, and when used properly, it gives information. Then what? What are the cystoscopy findings? Has anything been done for this patient? Okay. Left ureteric orifice 3 millimeters from the defect. Right ureteric orifice 1 centimeter from the defect. So what do you do?
Was an RGP done?
Yes, sir. RGP was done. I could not retrieve the images, sir, but it was normal, sir. Both the ureters were normal.
Okay.
Okay.
So you have to give some time for the patient to improve nutrition and
So now, okay, she is now ready. What is the usual time that you would say that it's okay to operate on a BBO?
6 weeks.
6 weeks. It's already 2 months now.
But
You know,
hemoglobin, albumin, everything we have to optimize. So,
That with 2 transfusions you can correct.
one thing you must remember, obstetric fistula are different to gynecological fistula. Number one. Number two, this is not really an obstetric fistula in the true sense.
Nitrogen.
Huh? Yeah, it is an unfortunate situation, iatrogenic. Now, when you have a fistula which is a gynecological fistula, you want to know whether it was a laparoscopic procedure or was it an open operation. What are the difficulties encountered during the operation? Is it possible to get hold of this person's notes or talk to surgeon? What was it? That caused all this drama. Was it difficult there inside the building? And then decide as to whether you want to operate at 3 months or 6 months or 6 weeks. Okay? Everything depends on the tissue quality. Too soon, tissues will cut through. Too late, patient will go on hanging around waiting. So you got to be sure what you want to do. So in most situations, if it's a gynecological fistula and it has been a laparoscopic repair, you can go on earlier. 6 weeks or whatever it is, some people will do. Generally speaking, people wait for 3 months. Let things settle down.
There are many people who operate at 2 weeks. If it's been a clean hysterectomy and it is an inadvertent injury, operate early.
If it's a pure ureteric injury, if it's a pure ureterovaginal injury, I have done it within 10 days or 2 weeks or 3 weeks. It's not easy. There's a lot of granulation, there's a lot of oozing and everything else. But sometimes in certain situations, for patients become desperate, especially if they are from far away. They go, come back, can't be, can you stay, wait. So you may have to bite the bullet sometimes, but knowing fully well that this is not going to be easy, and you can probably do a ureteric operation rather than a vaginal procedure, VVF repair. That's much more dissection involved. There's much greater chance of a VVF failing than a UVF failing.
Yeah, if I may, it is 2 months now.
Yes.
So it's late. But if you discover it on the morning after surgery, you can even go ahead and stent the ureter.
Correct.
Yeah, now that we've discussed all this, can you tell us what you found operationally?
You've done the operation? What are the other issues related to the operation that concern on the basis of cystoscopy?
The ureteric office are very close to
Yes.
the infection.
Yes. So what is likely to happen?
You injure the ureteric office.
Injure the ureteric orifice.
So
what is your basic idea? What is the plan in your mind when you do an operation like this? What should be your thought processes? Vocalize it now.
First is we have to know which approach, transvaginal, transabdominal.
Yes. What will you do in this case?
Transabdominal.
You will do transabdominal. Why?
Because it's close to the orifice, we need a...
Right. Is there any difficulty you anticipate in the transabdominal approach in this patient?
Yes, regarding ureteric orifice.
Hey, Baba, you just said something very important. What is her BMI? She's a fat lady, man. It's not easy doing a VVF repair, whatever it is, in a fat person. And in a fat person, if you can do it vaginally, all the more better. But here, there's a problem with the ureter.
And there is also that collection or cyst or whatever.
Yeah, there's urinoma there. So while your aim will be to close the fistula, anything else that comes in the way of the closure will have to be dealt with, irrespective. So, to hell with the ureter, I will re-implant it. The fistula has to be closed. If the ureter is in the way, I will move it out of the way, re-implant it. But I must get adequate, tensionless, good approximation to allow healing to take place. If you are going to compromise on that, because the ureteric orifice is very close, it's bound for disaster. So what you need to remember is that the left ureter is close. So when you make your vaginal, flaps or whatever you want to do, veer it towards the left, because anyway the left ureter is going to go. Try to preserve the right side so that you veer whatever you do on the left, keep the right ureter. But if it's not possible, it's bang in the middle in the trigone, both, you may implant both ureters. What to do? You're a urologist. So they said, the first time in is the best time in.
You can re-implant the left ureter into a safe position on the bladder and then go ahead with the bladder closure. Okay, we can't sacrifice that kidney just because the ureteric orifice is close to the fistula.
Kidney is very good.
Sir, in this patient, we had done a transabdominal approach and transvesical repair of the vesico vaginal fistula and bilateral ureteric stenting, sir. There was no reimplant done.
Okay.
But
I would say there is always a little risk when we have a ureteric orifice so close, because even a repair is going to fibrosis and contact.
She had a
It's very dangerous. I mean, I'm very impressed that you were able to close the VVF without even.
No, but she had recurrence in post.
So the plan was to do a reimplant that was changed on table, and on day 5 she had a recurrence. The bites on the left side were taken very thin.
Close to the ureter.
This is what happens. This is what happens. You compromise because you're a urologist, man. How do you reimplant the ureter, man? What's your problem? Huh? Frankly, this is not the first time I've seen this. All the time. All the time. The ureter is in the way. You are shy of reimplanting the ureter. So you do some adjusting here and there. It fails. Because it takes another hour to dissect it out, put it in, So what do you want to do?
Sir, one more thing I would like to add. Intraoperative, after a repair, we try to fill the bladder up to 200 cc to look for leak.
Okay.
Yeah. Is it allowed, sir, to distend the bladder after?
Yeah, it's allowed. It's all allowed. It's allowed. You can do it.
It is recommended.
You can do it and see sometime. You don't know to check. Even in a patient who has got no fistula and you've done a bladder operation, you close the bladder and you fill the bladder and see if there are any leaks and you put an additional stitch there.
One point was raised in our morbidity meet that if we had done a repair of a patient who is on 9 months, after 9 months of the surgery, I think, she was bladder was not distended. So
9 months after, 2 months only after surgery.
No,
9 months after the bladder surgery.
Yes, sir. 9 months after the fistula, sir.
Yeah.
So she was continuously leaking. Bladder was not distended for 9 months.
Okay, so
and we suspected the bladder capacity was small, and if immediately after surgery, if we distend.
This is what. See, you have operated on patients with chronic renal failure.
Yes, sir.
Waiting transplant. No urine coming. No urine coming. What happens to the bladder?
Exactly, sir.
No, exactly means
not exactly. What happens?
Yeah, the bladder is dry, sir. In that case,
bladder is dry. Baba, the bladder becomes small only if it is diseased. Full stop. Disease. Okay. That's all. You're born with a good bladder. As long as it is good, it remains good. Neural system intact, it will fill, it will empty. It's got its own brain. It's got its own brain. You don't have to fiddle around with it. When there is disease, when you have intervened, when you have given radiation, when you have done, when there is neurological defect, then only the bladder will say, well with you, I've got my own system to work. So then where you have, that's where the history is very, 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 very important. Remember that.
Okay, sir.
If she had normal voiding, no incontinence, nothing before the operation, you fill up blood rub, she'll have normal voiding. That's all.
Something which is routinely done is to assess the bladder stretchability once you open the bladder, to know whether it's restricted or whether it distends well or not. If it doesn't, let us say you find it tough, the bladder walls aren't moving as much as you expect to, all the more reason to take the ureter away to another place. And then you have to really see whether it is the bladder or the adhesions surrounding the bladder which are causing the problem. Not that you can do much about the adhesions.
Post-operatively, sir, the stents were removed and under anesthesia we examined. Cystoscopy, we didn't distend the bladder, but per specular examination, there was some small leak from some other side. So we are not sure whether it was missed.
So what will you do now?
Sir, we have asked the patient to come after 6 months for.
No. Let us say patient will come, do everything as you instructions. What is your plan?
So now my plan is that after 6 months I am going to do cystoscopy again, and maybe I look for another fistula, maybe which I.
Why wait for 6 months? It will cicatrize even more.
No, when the leak started day 5 after the operation, isn't it what you said?
Yes, sir.
When the leak started day 5 of the operation,
Yes,
would
sir.
you have left the stents in place for longer, knowing that there's a problem, that you compromised on that?
Yes, sir.
And then leave the catheter a little longer rather than keep it and hope for the best that it heals, rather than be in a hurry and take it all out?
Sir, it was
You know
like.
that it's leaking. See, you know it is leaking. Now you're trying to, scratch around, buy time, all the rest of it. So what do? You wait. You wait for things to heal. It might heal. You never know.
Yeah, that was only done, sir. 3 weeks, Foley was kept. Foley was draining. As soon as the Foley was removed, the leak continued the way it was before.
Now, why did you remove the urethral catheter?
After 3 weeks, sir.
Correct. Why did you remove it?
Leak. No, you could have kept it longer. Give it enough time. You don't know how much time, but give enough time, man. Give enough time for all these things to heal. What is that?
Sometimes we have these protocols too, 3 weeks, 5 days, 7 days, and so on. But this is an extraordinary situation where with the catheter, with the stents, there is a leak.
Actually, sir, 5th day, there was a Foley blocked and there was a.
Right. Now some more story is coming.
No, sir, I'll get back.
This is one operation, I'll tell you what. This is one operation where we insist on hourly urine output. Like a transplant. Hourly urine output. That is the only job the nurses have to do.
Did you leave an SPC?
No, SPC was not there, sir. We have just exchanged the Foley and.
No. At the time of the surgery, did she have both a urethral catheter and an SPC or just a urethral catheter?
No, sir. Only for urethral catheter, sir.
See, that's another practice which we've found very helpful, to leave a SPC. Because the urethral catheter itself is quite an irritation. So in case you find something like this happening, you can take out the urethral catheter, manage with the SPC. And the second thing, of course, is that you're providing double drainage. So you're trying to keep the bladder.
What was the position of the patient during the operation? What is the position of the patient during surgery?
Sir, initially it was lithotomy for stenting, then we made supine, sir.
I'll give you a better piece of advice. you've got an obese lady, whether it is obese or whether it is thin. Try to do these VVF repairs if you're doing them abdominally with stirrups in the Lloyd Davis position, 1 person between the legs to elevate the vagina so that you can dissect it out comfortably. This is a fat lady. You will be wallowing in fat, you'll be wallowing in the depths there, and you'll have difficulties. All right?
Okay, sir.
So my advice is put these women in the Lloyd Davis. If you got Allen stirrups, put Allen stirrups and put it. Make it comfortable.
Okay, sir.
Listen, you have played cricket, huh? Have you played cricket?
Yes, sir.
With the coach or only with all your fellows in the lodge, in the apartment? The first thing the coach tells you when you play cricket is that you have to wear comfortable clothing. Don't wear tight pants, tight this, tight that, and go there and you sit at everything will tear. So you have to be comfortable as a surgeon when you operate, especially knowing that this is a very dicey situation. VVF is a very dicey, very tricky, very, very tricky.
Vaginal access is imperative.
So you put the patient comfortable, you be comfortable, everything must be comfortable. Good exposure, not this small exposure, you try to fiddle around. Dissect the tissues out, take out all the tissue which is dirty, get the edges which are supple. That when you put the stitches, they must hold nicely. You should feel happy that when you're putting your knots and tying it there, that it's not under tension at all. If it's under tension, don't put it, don't proceed. Dissect some more. Dissect some more and get the tissues nicely. Is ureter come in the way? To hell with the ureter, reimplant it. So, first time in is the best time. There's nothing else you can do about it, unfortunately. Rightio.
Anything else? Any questions from anybody? Right, then I think we can wind up for today.
Thank you.
Have a nice week. Catch up next week.
Okay, thank you, sir.
Thank you, sir.